Can you hear me? Okay. You can hear me?
Yes.
Got it. All right. So thanks everyone for joining today. And it's always a pleasure to be able to speak to caregiver groups because caregivers serve a very vital role in what I do every day. What Sharon mentioned was I'm not noted and prominent, but I am Dr. Carrol. I'm one of the physicians. I'm the lead physician here at West Los Angeles Medical Center. And so my primary role is I work in the memory care clinic. And in that role, I'm responsible for meeting with patients, meeting with families in order to do the initial evaluation to determine if the changes that they are experiencing, if their changes in memory loss are normal for age. And it's important to note that there is a such thing as normal memory loss. And so we always have to be aware of that. And if the changes in their memory is abnormal for age, to determine to what extent those changes have occurred and are they to the point that they're impacting the person's ability to be independent. And so my day-to-day truly involves not only working with patients, but working with families that get along, working with families that don't get along, working with spouses and various different situations. And as a result of my interaction in that space, I have an opportunity to form bonds and learn more about the impact that caregiving can have on the caregivers. And I like being able to speak to the caregivers specifically because it's important that they take care of themselves when taking care of mom, when taking care of dad, when taking care of our siblings, when taking care of our spouses. Because this disease process, and the disease process we're talking about is dementia. This disease process is often described as the slow goodbye. And it's not like cancer, it's not like heart failure, it's not like COPD, that yes, those conditions can truly impact you. But with dementia, it's such a debilitating condition that it lasts for a very long time. And we see our mom, we see our dad, we see our siblings, we see our loved ones go through all these changes, and really has a detrimental impact on us as caregivers. And so that's why we like to create this space where caregivers can come together. And I'm very appreciative for ACTS for always having this space. And, Jeannie and Sharon have always been very welcoming to me and welcoming to all members of the community to create that space where you guys can come together and talk about what you're going through, talk about what has changed over time, because it's through that space that we're able to work together and grow together. This condition, it has no cure, unfortunately. There's always new medications that could come out. So there may be a question today about the medication that came out last year, but there is still no cure for this condition. So all we have now is the importance of the environment, which is really built on who the caregiver is and what that support system is like. So you guys serve a very vital role. Before we kind of get into questions, I did kind of want to review kind of what dementia is and how there are various different types, because that's often a big question that I deal with in the clinic. And then we'll have the space for questions as well. So you guys can ask, what concerns you have, and we can go from there. So if we think about what dementia is, so imagine dementia is a house, okay? So everything in that house is dementia. So what is dementia? Dementia is a condition that involves not only memory, but it involves changes in thinking, changes in mood, changes in behaviors, changes in language, the person's ability to communicate. And those changes occur to the extent that it impacts the person's ability to be independent. So it's not only just that mom can't remember what she did yesterday. It's not only that we can't remember what we ate this morning. It's not that, I sometimes have a hard time coming up with the words that I need to say. These changes have to occur to the extent that it impacts a person's ability to be independent. So it's not that I just forgot what I ate yesterday, it's that I forgot to pay my bills the last 3 months. It's not that, oh, I missed, I misplaced something in my house, I can't find my keys. It's that when I do find my keys, I realize I put them in the refrigerator or somewhere that's inappropriate. Now, there may be people on this call that are laughing, and I'm not saying it's anything wrong with that, but these are exact examples that I'm experiencing in the clinic, because it's not only just changes in memory, it's changes in thinking. The person knows that they have to put this thing somewhere, but the way that their mind is currently wired, they're putting it in inappropriate places. So we have to be aware and be very keen and in touch with kind of what's going on around us. So you have those changes in memory and thinking and language that occur to the extent that the person is unable to complete tasks that they used to be able to do on their own. When it is mild, I've heard someone, I think it was one of the persons that was joining for the first time, they mentioned that mom had the early stages or mild stages of dementia. So when we use those terms, that can mean a variety of different things, because there's different ways to kind of classify it. But generally speaking, when the condition is mild, it only impacts their highest level of functioning. So their ability to remember to pay their bills, or their ability to remember to take their medications, or their ability to remember where they're going when they're driving to routine places, not to the place that they've only been once, but knowing where the Ralph's is around the corner, things of that nature. So when it's mild, it only impacts those highest level things. So the cooking, the cleaning, the paying the bills, the driving, the taking their medications. But when it becomes more moderate, it impacts what we call hands-on care. So all of that is hands-off care. So things that they don't really have to do, like the cooking, the cleaning, things around the house. Hands-on care, they may forget how to put on their clothes or the order in which the clothes go. So that's hands-on care. They may forget how to bathe them, not how to bathe themselves, but know what needs to be done. Okay. So it's not that they physically can't reach their back, it's that they don't know that needs to be done. So you have to be able to differentiate that. And I'm not saying that this is up to each of you to determine, oh, she can't physically do it, it's cognitively, but this is what we do a lot when we're talking to patients and families in the clinic. So when I go back to that house model, when we think of what dementia is, everything in the house is called dementia because the house is dementia, but each room is a different type of dementia. Okay. So the biggest room in the house will be Alzheimer's. Yes, I said Alzheimer's. Alzheimer's is not different than dementia. It is a type of dementia. So the house is called dementia. The biggest room in the house will be called Alzheimer's. So I'll often hear patients and families say, oh, I'm glad you told me I have dementia as long as you didn't tell me that I have Alzheimer's. Or at what point will this become Alzheimer's? But it's important to note that our pictures or our thoughts of what Alzheimer's is, just in the community, including me as well, sometimes we only think of Alzheimer's as the end stage. We think of Alzheimer's as they don't know who their mom is. We think of Alzheimer's as they don't know where they are. But you can have mild Alzheimer's that can eventually become severe Alzheimer's. So that's all still dementia. It's just the most common type. Now, I personally tell people this all the time. I actually blame me and my colleagues for making the community think that there's two separate things, because you'll even hear on commercials, Alzheimer's and dementia. Alzheimer's and dementia. So you'll hear it as if they're two separate things. But the reason why is because the majority of people with dementia, they have Alzheimer's. So sometimes we're using those interchangeably, but not really tying them together. That is Alzheimer's dementia. Okay. So everyone in the house has dementia, but not everyone in the house has Alzheimer's. That's just the biggest room. 60 to 65% of the people with dementia, they have Alzheimer's. But again, that gives us about 35% of people without Alzheimer's that still have dementia. So there are other types as well. The other types include vascular dementia, which can occur when there's multiple small strokes or one large stroke that impact the person's memory and thinking. So that's vascular dementia. You can also have frontal temporal dementia, which is very rare, but it's more common in men and in younger populations. It's stark changes in their personality. You can have Parkinson's dementia. These are patients that have had Parkinson's disease for a period of time and then develop dementia. You can have Lewy body dementia, which is another type of Parkinson's type that involves some very frank hallucinations that can occur. You can have mixed dementia. So that means you have kind of multiple different types. And the reason why we kind of talk about mixed is because there are certain symptoms that are more common in certain dementias than others. Although as it progresses, all of the symptoms start to be alike. So yes, frontal temporal may have some stark personality changes at the beginning, but you may also have patients with Alzheimer's that can have personality changes as well as it progresses. So it's a key to understand it matters, but it's not, okay, let me take that back because I know this is being recorded. So it does matter that we know what type of dementia, but it's not to the extent that if I don't know exactly what type mom has, I don't know what needs to be done, because a lot of the management techniques are the same. The reason why it somewhat matters is one of the rare forms of dementia, frontal temporal dementia. There is some data to support that even trying some of the medications that are approved for dementia, if you try it in those patients, it can cause symptoms to be worse. So in situations like that, it does matter. Or in situations like Parkinson's dementia or Lewy body dementia, there are certain medications that we often use to help with behaviors that can't be used in those patients because it can make certain symptoms worse. So as much as possible, I tell people this is why we have to talk about these conversations. We have to have these conversations early and often, because as it progresses, a lot of the different dementias look alike. But how things start at the beginning help us understand potentially what type of dementia it is, and it can help us predict how we can manage this person down the line. So if I see a patient that's had dementia for 5 or 7 years and they have a lot of the symptoms, I don't really know what type it is. I can be pretty sure that it is dementia, but I may run the risk of potentially prescribing a medication that if I knew kind of how it started, it would potentially impact if I chose that medication or not. Hoping that makes sense to everyone. So that's why it's important to have that conversation early and often. Other things that may come up is someone mentioned about, I think it was you, Miss Linda, talking about maybe having to move mom out of her house. And so, there are various different reasons why we may have to move mom or dad out of their house. It doesn't always have to be dementia. It can be physical function decline as well. But I can tell you the 3 things that we struggle with as we age, even outside of dementia. The 3 things that we struggle with as we age is when someone has to drive for us. So that means that we lose our independence with driving. When someone takes care of our finances, because no one can count money like yourself. And when someone tells you you have to leave your house. Because all of those are wired to be linked to your level of independence. Even now, we're sitting in our own individual spaces now, and you're like, this is my house. No one can tell me where to go. This right here, this is mine. I pay the mortgage, or I pay the mortgage every year or every month. This is my house. So that's always a difficult conversation to have, regardless if the person has dementia or not. So that's you have to be very cautious, not cautious, but you have to approach it with very much care. You have to approach that conversation with much care. And I do that as well. I don't do that type of conversation as often outside of dementia. I'm a geriatrician by training. So I focus on the care and needs of patients 65 and older. But for the last 6 years or so, I've been focusing on memory loss, because that's something that's very near and dear to my heart. And so I work primarily in this space of dementia care. So that's pretty, I think I wanted to kind of tell you guys what dementia is. There's a lot of different manifestations, a lot of different behaviors. Oh, one other thing I want to say before we open up for questions, sorry about that. When we often talk about dementia, at the beginning, what brings people to see me and what brings families to conversations like this is changes in memory. So think of memory at the middle, right? But as time progresses, we realize that we have to think for dad or think for mom. So we become their brain. But what causes us to be exhausted, what stresses us out as caregivers is not the memory loss. It's the changes in the behaviors. It's the resistance to help. It's the changes in mood. It's the changes in sleep. So I've had patients and their families say, Dr. Carrol, I can take care of the memory. I mean, I just got to pay his bills. I got to make sure give him his medications, but I can't take him walking out of the house. I can't take him not recognizing me when I come into the house. I can't take him doing some inappropriate things. And these inappropriate things can be on the spectrum. I could talk about that all day too, but I can't take these changes in moods and behaviors because that's what's exhausting. This person isn't sleeping at night. So that's not really memory per se, but that just shows you how dementia sort of eats away at who the person is. And it impacts us day to day. Okay. All right. So we can open up for questions. Kimberly, thank you for allowing me to get that space.
Thank you, Dr. Carrol.
Anytime.
So everyone, either you can come off mute to ask your question or, and Brenda, I see your hand, so we'll start with you first. But before we do that, you can either raise your hand or you can type your question in the chat and we'll just kind of go back and forth. I'll either call the person's name or I'll read the question in the chat. Okay. Brenda, you want to go ahead and kick us off? Thank you.
Yes, just kind of wanted to use what Dr. Carrol said about the night sleeps and stuff, because last night was a difficult night with my mom with her sleep. I think I got an hour sleep up and down. And so, and thank you for our sister member from last month that recommended contacting Dr. Carrol about the medicine trazodone or whatever to help her sleep. And so I've been giving it to her, and I've been giving her a half a pill because the full pill, she would wake up kind of groggy. But after last night, she's having these dreams or nightmares to the point that she's screaming out in her sleep and her eyes are closed. She's asleep, but she's like she's in it. And so I had to shake her and wake her up. And she said she was having a bad dream. And so off and on throughout the night, she was very restless. And so besides the medication, is there anything else that I should be doing or being a cognitive of? Because I know the dementia is progressing. But last night was an interesting one. It kind of scared me when she was screaming out in her sleep or whatever. And then when I woke her up, she kind of looked at me dazed. And then I calmed her down and got her back. But is there anything else that I should be doing to kind of deal with this or understand or prepare for her at night?
Sorry, I put myself on mute so I can make sure I was paying attention. So one thing I like to say when I'm answering questions, I'm going to answer them. I'm going to answer them specifically, but still somewhat generally, because I don't want to kind of go into what else is this, is this going on, things of that nature. But to your question, Brenda, what I would say is it's always important for us to do a medication review, just to kind of see what else could be causing those changes. Yes, we often use medications like trazodone to see if it will help initiate and maintain appropriate amount of sleep, but a lot of the side effects are potentially dose dependent. And you also have to keep in mind that a lot of medications that are prescribed, sometimes once you get to a certain dose, the unexpected consequence can occur. Okay. For instance, you may have people that say, oh, just put mom and dad on melatonin. But we get to a certain amount of melatonin, there's an increased risk for hallucinations occurring. And people don't realize that melatonin itself can cause hallucinations. We thinking it's supposed to help the person sleep, but it may cause them to have more problems with sleep. So just kind of understanding that. I think the best thing for you to do is, and we say this often in geriatrics, is start low and go slow. So try to find the lowest dose possible that can help mom initiate and maintain sleep. And trazodone itself, just generally speaking, is an antidepressant, but we take advantage of the fact that one of the potential side effects is it makes you sleepy. So I've actually had patients use trazodone earlier in the day, so that it's not as fresh in their system right at night. And so that could potentially help mom sleep a little better. A lot of medications can make you have vivid dreams because it sounds like that's what you're describing. Her dreams are so real that she's like, I can't get a good night's rest. And so we have to be cautious about that, and we have to be willing to make the necessary changes. We can't say, you know what, the doctor gave me this for sleep, so that's what she's supposed to take. You got to be like, this not helping her, like this making things worse. So we got to shift gears, adjust dose, move to a different time of day, things like that. Okay.
Thank you, Dr. Carrol.
Anytime.
The next question says, what's on the cusp in terms of Alzheimer's prevention?
Okay, great question. I'm not sure. I want to know. So Jan, okay. I just want to make sure I knew who asked it, so I had to pull up the chat. So what's on the cusp as far as Alzheimer's prevention? So a lot of it relies on diet and exercise. A lot of it relies on identifying these genes and variables, trying to do these tests earlier in life to determine if the person is more likely to develop dementia along the way. The best thing we have now is diet and exercise, and I can share things with Sharon and Jeannie about that to put that on the website. But we do have what we call a brain healthy diet. And that's the biggest thing that we have now. So watching the amount of fried food that you're taking in, making sure that you're exercising. A lot of my colleagues talk about diet and exercise, but I personally add engagement and activity and sleep. So we don't really realize the importance. We often, as I tell people, we sleep on sleep. We don't realize how important it is for you to get a good night's rest. And engagement, your level of activity, you're staying active, once I retire, I'm not retiring to stay at home all night. I'm retiring, but I'm reinventing myself. I'm finding my second win. I'm entering my second act. All of that is important. One thing I can say that it's a lot of controversy around, and a lot of this stuff is available now, is gene testing to see if you have certain genes for potentially developing Alzheimer's. I want to be honest. So I have some patients that will come to the clinic with results of gene testing or inquiring or asking me about gene testing. I am on the fence about the effectiveness of it because when you get this gene testing at a young age, if we don't fully know if just because you have that gene that has been linked with dementia that you will develop it. So it's very difficult to counsel patients and families about something that they may have done a couple of years ago, because what happens is, Jan, I'm not saying you did this, but if you come to me and say, well, Dr. Carrol, it says I'm going to develop dementia. It's hard for me to counsel you because mentally you're second guessing yourself all the time because you're like, I know this is coming. So just because you may have that gene, it doesn't necessarily mean that will occur to you. And so I still want you to focus yourself on the diet and exercise, staying active, staying engaged, getting a proper amount of sleep so we can quote unquote beat the genes, if that makes sense. Mm-hmm. It's not saying that, Jan, you're automatically going to get it because you have this scarlet letter on your chest that this is what's going to happen to you. There's a lot of money being poured into early detection because we're trying to move it farther upstream. We spend a lot of money on treatment years and years. Now we're trying to focus more on early detection because we see the impact that it can have, and we understand if we detect it earlier enough, how we could potentially help the patient and family make important decisions when they need to. Okay. So as far as what's on the cusp, is really trying to identify it as early as possible, encouraging people to be evaluated early, diet, exercise, engagement, and appropriate amount of sleep.
Thank you.
No problem, Jan.
Thank
All right,
you. I'm going to actually go to Ms. Foley. I want to acknowledge your hand, and I'm going to read a couple of questions that came in the chat, and then we'll come back to you in 1 second, Ms. Foley. Okay. So Dr. Carrol, Leslie asked, 1, are you accepting new patients? Her mom is 62 years old with dementia. Her PCP referred her to a neurologist instead of a memory care specialist because she's not yet 65. Is there another way to get her to see you without a referral from her PCP? Number 3, what's the importance of dementia medication? Number 4, what are the pros and cons of taking dementia medication? Any negative side effects if she doesn't take it? Joy has a similar question about getting her, she'd like for you to assess her sister who's been diagnosed with dementia. So she's also asking how to connect with you, and I'll stop there.
All right, so good question. So what I would say, I'm in the Kaiser system, and so the person would have to have Kaiser insurance, and that is a limiting factor for me, just because I only see patients in the Kaiser system. That's just the way that the system is set up. 2, we do have a cutoff, unfortunately, for patients that I can see. And Sharon and Jeannie know this story very well. So I'm the only one in all of West Los Angeles in the Kaiser system that sees patients for memory loss. So we had to cut it off at 65 because otherwise I would be seeing everybody. So I do apologize for that, Leslie, but if the patient is not 65, and that is an arbitrary cutoff, like why do we choose 65? But we years and years ago, they used 65 to determine when geriatric starts, because that's when Medicare started, and that's when most people were starting to retire. And so we've continued to use that as the marker. But I can say, Leslie, that my colleagues in neurology, who I work with quite often, we end up sharing a lot of patients because either the patients have really bad behavioral disturbances, or it's a lot of stuff going on that I may see more often than them. Then they will reach out to me for advice or some guidance as far as that's concerned. So I do end up commenting on patients that are younger, even if I don't, quote unquote, see them myself. I do truly trust the neurologists within the Kaiser system. And I'm assuming, Leslie, that mom is within the Kaiser system, but I do truly trust them. And another reason why we use it is because the majority of the cases that occur of dementia, they do occur after the age of 65. Any time before 65, there is a different way to assess the patient. Just because it occurs earlier than what we would expect. And so there may be more extensive testing. Now, I'm not saying that if a 75-year-old comes in that I won't do the appropriate amount of testing, but it's a different approach if a 45-year-old comes in with a certain amount of changes in their memory and thinking. So they will have to go through some additional tests, whether it be more these are sometimes more invasive testing to determine if it's something else that's going on versus then a 75-year-old person. I'm trying to remember the other questions. I can look at them now myself. Kim, hold on. Yes, we only operate off a referral. So mom has to have a referral. What's the importance of dementia medication? So there's a lot of debate about that. There are, depending on how you look at it, about 5 or 6 medications that can be used for dementia. There are about 4 in the first group, which is for mild dementia. So that's when the person's only having changes in their memory and thinking that impact their highest level of function. And then there's 1 medication in the second group that's for moderate to severe. Now, these medications are not the cure. So when people say, what's the importance of the dementia medications? I have no problem with us trying it because the data supports that it can potentially slow down the decline. Does it stop it? No. Does it reverse it? No. However, you may run into patients and families that say, oh, I went to see Dr. Carrol and he didn't even prescribe my mom a medication for her dementia. So I don't know, what he's talking about. The issue there is when we're talking in the clinic, I am evaluating each patient individually. So some cases, there's no need for us to talk about medications for dementia because one, the issue could actually be more behavioral, which these medications for dementia don't initially, since they don't really target the behaviors. So I may say, let's try something that's gonna target mom's agitation or aggression, or let's target something that's gonna target her sleep. Because I'm not going to be starting 2 medications at once just for the sake of saying she has dementia, I'm going to treat the dementia. We have to treat what's going on as far as her mood and behaviors first. Another reason why I may not put a person on a medication for dementia is because he or she may already be experiencing some of the side effects that we worry about when patients are taking dementia medications. For instance, as Brenda was describing, patients that have really bad changes in their sleeping habits. So most of the medications that are prescribed for dementia can disrupt your sleeping habits. So if a person's already coming to me saying mom or dad is having really bad sleeping habits, I shouldn't be prescribing a medication for the sake of saying this is for dementia, because that can make things worse, if that makes sense. So the pros and cons, of taking dementia medications. I think the pros are, it's important to give it a try if there are no contraindications, if there's nothing else, if there's nothing that we can say mom or dad does not need to try it. The cons are, the cons are the risk of side effects. It's not the cure. And often that's the important conversation that we have to have with the patient and family. When we are prescribing the medication, I always say this isn't the cure. So when patients and families think it is a cure, sometimes it sets them up for failure because they feel wed to the medication. Like they take this medication once a day, things are going to be better. And then as a result, if they don't understand that it isn't the cure, it can then impact their ability to accept the changes that are going on because they think that it should have stopped it or they think that it should have reversed it. So that's one of the cons. Any negative side effects, if she doesn't take it, I would actually say there are no negative side effects if she doesn't take it. It's just if she's already experiencing concerns that we would be worried about getting worse if she does take it, then that's an issue. Now,
Okay.
I don't know if I
think
answered the second group.
You
Yeah.
did. You did. So thank you, Dr. Kelly. Oh, Dr. Jarrod.
It's all good.
Dr. Jarrod Carrol. Next, we'll go to Ms. Foley.
Thank you. Thank you, doctor, for being available to us. My concern is that my husband and I were fairly new to the community of dementia. My husband was diagnosed about 2 years, a year and a half. And I don't actually know how we got there, except the gerontologist gave him an evaluation and diagnosed him as having mild cognitive impairment. I didn't dispute that because I did know, and my husband did know, that he was having memory issues. And I do know that during the period since then, his memory has gotten worse. However, the other aspects of him being able to manage some cognitive things are still intact. He can still drive, although we limit it. We go kind of in the neighborhood, and I'm usually with him so I can monitor and see, make an assessment. But he has never seen a neurologist. And so I don't know how we got to the gerontologist. And now I don't know, I don't want to I don't want to have not enough intervention or too much intervention. I want to have my husband retain as much of his self-work, functioning, all that, without my assuming that, oh, we better check this out, you know. So I'm needing more help about just being able to understand progression and when is it just stabilized, and are there conditions that just stay stagnant as you grow older. My husband is now 79. So he can remember he remembered to repair an electrical outlet, but he doesn't remember if he walked the dog or fed the dog. So help me.
Thank you, Ms. Foley. So those are good questions. So you actually highlighted some key words that I think it's good for me to talk about for a second. So you mentioned that your husband had been diagnosed with mild cognitive impairment.
Yes.
And so often mild cognitive impairment is seen as the midway between normal aging and dementia. And again, dementia is a broad term. So it doesn't just mean Alzheimer's, it's all different types of dementia, right? So mild cognitive impairment would be seen as the midway between. So, and again, I won't go into specifics as far as your husband's case, but generally speaking, when a patient has been diagnosed with mild cognitive impairment, they don't have dementia. They're where my head is. Mm-hmm. Okay. And what mild cognitive impairment means is there is a noticeable decline in the person's memory and or thinking. So again, it sounds like it's dementia, but the difference between mild cognitive impairment and dementia is mild cognitive impairment, there is no significant impact on the person's ability to be independent. So it's not to the extent that they kind of cross the finish line to say this is definitely dementia. Patients with mild cognitive impairment, for example, do very well with the appropriate structure in place to make them remember things. So they will do well with the pill box. If we set up the pill box, they'll be able to kind of do it themselves. Patients with dementia may have difficulty even with the pill box being there. They may have difficulty remembering to go to the pill box to take the medication. Just using that as an example. So if your husband has been diagnosed with having mild cognitive impairment, if there hasn't been any other evaluations between then and now, technically he does not have the diagnosis of dementia. Okay, he just has mild cognitive impairment, not just has mild cognitive impairment, but he has mild cognitive impairment. Now, patients with mild cognitive impairment are at increased risk of eventually developing or transitioning to dementia. So it is important to check in and check up of what's going on, what has changed, is the decline to the extent that we would classify it as dementia at that time. And patients with mild cognitive impairment or MCI, they're more likely to eventually develop Alzheimer's. That's just more commonly. You mentioned something else that I wanted to say. Oh, does the patient have to see a neurologist? So I'm not a neurologist. So you don't necessarily have to see a neurologist, but I do understand that prior to the growth of geriatrics, neurology was seen as the major group of providers that would diagnose and manage dementia. I work with neurologists all the time. We have similar approaches, not the same. We have similar approaches to managing patients. A patient doesn't necessarily have to see a neurologist, but I do respect that often that's seen as a step that's needed in order for families to feel like they've had the appropriate amount of support. So he can see a neurologist. You can request that he sees a neurologist so that they can do an assessment versus the geriatrician who you were referring to.
Thank you so much. That's very helpful to me.
No problem, anytime.
Awesome. Next up, we have Billy Johnson.
Let me come off mute here. First, let me just make a comment, Dr. Carroll. I'd be remiss if not, but Dr. Carroll has been involved in helping my family with my mom for a number of years now. So I think he's been compassionate. I have to say this, he did ask me, compassionate, caring, and been very, very involved. And so my question is this, Dr. Carroll, with our experience where my mom was living with some level of care, and then she had a fall in 2021, and then had to go into full-scale 24/7 care facility. So had to be moved out of her home. So a lot of things you've talked about, we've had to go through that in a rapid stage. So my question is this to you, is what can we do to be better prepared for the times we got to be in the relocation? What are the things we can do to make sure we can be the best combined caregivers and providers and working with you and other medical professionals? Because I felt you guided us, but we had to pull a lot of things together. We weren't as prepared as we could have been. So what can we do to be better prepared to make sure that when those sort of things occur, and in our case, it occurred rapidly with her having a fall and then not going back home, what are the things we can do to make things go better, be more organized, to provide support?
So great question, Billy. And believe it or not, I have this conversation on a daily basis. And for whatever reason, a lot of the conversations involve someone in California with a family member in Texas. So so it's something about California and Texas. But so what I often tell patients and families is I'm actually working a lot in the background. So Jeannie and Sharon know that there are a lot of changes going on in my clinic. I'm working in the background in order to try to beef up our ability to support patients and their families from diagnosis through progression. Because we have to have these conversations early about the what could happen. Because often we just think it's memory, Billy. We just think it's memory, like, oh, mom's memory is a problem. We don't realize what could happen. So we have to have that plan in place. Just like we're supposed to have plans in place for if a fire happens in the house, this is what we do next. You know, this is kind of what happens next. And so if we have these conversations early enough where the patient is able to participate in these conversations, then it could potentially make things easier. But it's not just the patient that it makes it easier for. It could potentially make it easier for siblings if we are all on the same page, you know, because keep in mind, I only have a snapshot view of what's going on. So I often am more connected to the person who brings mom or dad to the clinic. So I have some cases going on right now. So when I'm pulled into the legal system about this person is doing this and this person is doing that, if we are not all on the same page, and I know that's not always the easiest thing for us to do, but if we're not on all the same page, we're pulling and pushing on who should help mom, who should help dad, where should mom live, where should dad live. But if we have all that outlined early, and we say, look, I'm going to help with our finances. This person will help with the healthcare. If it's not the same person, that can sometimes be a problem too, because as you get older, your health is married to your wealth in a way, just to be honest with everyone. Because if you need to be able to pay for your health, you got to have the wealth. So just kind of understanding the connection between those two. But having those conversations early are important. Now, I do think as a system, not only Kaiser, but all systems can do better in providing that support. So I'm trying to beef up our support. But Billy, I also have to remind you and everyone that it's also the family has to be on one accord as well. So it's partnering with each other to have a plan about the what ifs in life. Often when we see dementia as an isolated concern related to memory, we think that, oh, my sister can just stay in the house with her because it's just her memory. But if we don't realize that it can be some physical manifestations of the changes, the falls, and we don't have a plan for what could happen, then we are not prepared for that. And we're having to make quick, drastic decisions on that. Whereas if we are always kind of said, okay, if the next time something happens or the next time mom walks out, she's going to X facility, or she's coming to live with Billy, or she's coming to do this. But if we don't have that conversation because it's taboo and we always told mom, I'll never put you in the facility. Everybody on this call, we got to stop saying that. Please. We have to. It makes sense because we say it for ourselves and we say it in front of our children so they hear us say it to our parents so that they will say it to us. But we do not know what the future holds. What we need to be telling our adults, our parents, our siblings, our spouses is, I am here to provide for you as much as I can. I will make sure you're provided for, because there's no need for us to lose both of us by me saying, I told you I never put you in the facility, Billy, so we go be in this together. And you just declining and I'm declining, you not taking your medications, I'm not taking mine, I die, and then Billy left in the house that I said I would never take him out of. And it's just like, what were we doing there? What were we doing? So conversations are very important, Billy. It always comes back to that. Partnering with the organization that your mom or dad or you are involved in as far as health, and still having open and honest conversations with your family members.
Thank you.
No problem.
Dr. Carrol, Deb Collier says, I recently received a message about clinical trials for Alzheimer's research and that African Americans are underrepresented for inclusion of the effectiveness of the medication or other modality for Alzheimer's dementia. Are there any considerations or guidance for volunteering in clinical trials for Alzheimer's? And that's Deborah Collier. You're on mute, Dr. Carrol.
All right. The only thing I would say, I am fully invested in trying to increase the number of African Americans in clinical trials. I think that, there's a lot that can grow out and come out of clinical trials. I just always like to reiterate that when we enter into clinical trials, one, a lot of the healthcare is provided, but you enter it with a spirit of helping the next generation. And I always want us to think about it like that. Yes, it could potentially help mom. Yes, it could potentially help dad, but really it is trying to determine what the future is and how can we best improve healthcare. So I have, I'm hopeful that we eventually find a cure. I'm hopeful that we find a disease modifying agent that can reverse it or stop it. But I think sometimes people enter the clinical trials with the expectation that it's going to change the here and now for me. So often it needs to be a partnership or a continuance of what you're currently doing to help take care of mom and dad, and still trying to enter that trial and just kind of understanding that. So I think it's great to volunteer for the trials. There's a lot that can be learned out of it. A lot of new ways that we're learning to assess patients. I am not as actively, I must be honest, I'm not as actively involved with the clinical trials. Prior to working at Kaiser, I was at UCLA for training. And so I was more up to date on the trials in the sense of kind of knowing what was on the horizon, the here and now. Whereas now it takes me a little longer to hear a lot about it. And so, but I see the promise of clinical trials, and I understand the importance of it. So I'm completely with that, Deb.
Thank you.
Additional clarification.
Are you talking, Deborah? We can hear you faintly.
Yeah, I thought I heard her too.
Oh, I was just saying thank you for sharing that additional information. And I did notice that one of the trials actually was dealing with just if you think of the malfunction impairment, even that there are some here you said that it's I'll be paying more attention to it, even though I've lost the loved one to Alzheimer's dementia. I still have a vested interest to see what I can do for the next generation. I like that.
Definitely, Deb. And I think that's very noble of you to think of that. And although you have lost a family member to the condition, it still impacts you. because you could come to situations like this and hear from others about experiences that they're having. You may be able to offer them support or offer them tips for what worked in your situation, and to be thinking about how could I best help the next generation. That's key. So I applaud you for that.
Thank you.
No problem.
Thank you. Dr. Carrol, Joy asked, is a person farther along in the disease if they can't remember any of their childhood?
So, yes and no. So I would say, generally speaking, because it typically impacts memory first, and typically it impacts the short-term memory. So their long-term memory is generally intact. If I'm speaking to patients and their families and they're saying that, now dad can't remember where he was born, or now dad is saying he had 5 siblings instead of 3, so he's sort of like making up new things or confabulating what the truth is, generally that does symbolize that there is more progression there. The reason why I would say no is when we stage dementia, it's often based on your abilities and your physical abilities. So as I mentioned, the mild stages include the person not being able to remember to pay their bills, take their medications, know where they're going when they're driving. When you look at the staging system, and I can send that to you as well, the staging system very rarely comments on long-term memory versus short-term memory. It comments on the person's abilities to complete everyday tasks. Because again, dementia basically means there's a change in your memory that's more than what we would expect, and it impacts your ability to be independent. So it includes memory, but it doesn't necessarily differentiate between short-term memory versus long-term memory. One thing I can say that we do see a lot though, is sometimes when a person can't remember some of their childhood or a relationship that they have, it could be that it's being repressed because it was very traumatic. So keeping that in mind, often we don't want to talk about the traumas that we experience. So keeping that could be a layer of that as well.
Thank you, Dr. Carrol. Mr. Green, we thought we may have seen your physical hand up earlier. If you have a question, you can definitely go ahead and come off mute.
Unmute. Can you hear me now?
Yes, sir.
First of all, Dr. Carrol, you are amazing. I had quite a few questions, only because I've been on this journey for 12 years. Okay, and you could see my lovely wife here, hey, Pansy. Can you see her? Yeah?
Hey there.
Oh, okay, Pansy.
No, I love seeing patients. Now I love caregivers too, but I love patients.
Hey. So, I don't want to go on, but we've been on this journey, like I said, for 12 years. Pansy, when the disease was in earlier stages, was on the board of directors for Alzheimer's LA. I am presently on the board. Before Alzheimer's LA broke away from Alzheimer's Association, I was on the board then. Been very, very involved. So, it's all history. But I did have some questions. You answered them all, and basically was on the meds. And then you came in and you said it. It's okay. So we know there was Aricept and Namenda. And now because we have good insurance and could afford it, we are taking the Manzarek. And that you've already said it. It's no cure. We think that it slows it down. But anyway, so we are... and Sharon and Jeannie have been involved and are still involved. We've given talks. Oh my gosh, went back to Washington, D.C. for funding, to Sacramento for funding in years past. So I just want to say, and at one time or another, I would like to get your number because on this journey, and we're all in this together, I could have almost given a talk similar only because of my experience, but I'd like to talk to you sometime, okay? Dr. Carrol.
All right, sounds good, Mr. Green. So one thing I will say, so Mr. Green brought up a good point that he spoke about Namzaric, which is a branded medication. And Namzaric is a medication, it came out a few years ago. I think it came out while I was in training. So when it came out, it was a blockbuster drug. Everyone wanted to try Namzaric. Oh, can you put mom and dad on Namzaric? But what it is essentially two medications that were already on the market. They combined them into one medication. When patients were having problems tolerating medications multiple times a day, it combined those medications. So it decreased the pill burden, how many pills the person has to take each day. So it wasn't necessarily a new medication on the market. It was just that it was a different way of packaging. Does that make sense, Mr. Green?
Yes, it definitely does. You said it. One thing that I want to say too, this is so very important because I'm the sole caregiver. I do have someone come in and give me respite time, a few hours here, but we have to look after ourselves. In being involved with so many support groups, I have actually seen the caregiver go down before the caretaker, only because they weren't taking the time. And oh my God, I'll be 85 in a couple of months. I want to be 105.
I'm going to come to your 100th birthday party.
Right. So I'm saying I'm very aware of that. And, I've been on this before, but it's a journey, and take care of self. That's what I would recommend to anybody that is a caregiver. And get involved. I was involved with so many support groups. I said, I ain't worth a damn to nobody, or even myself. So I just cut it off. I'm only just a few. And this is one of the support groups. And I want to thank Jeannie and Sharon. I think I've been with you guys for about a year. And it's been very, very positive because most of the other support groups aren't with us. And I don't need to go no further. You know what I'm talking about. Anyway, good seeing you, doctor, and hope we could connect.
Sounds good. Thank you so much. And thank you for your commitment to your wife and telling your story, because we have to hear these stories of decisions that were made and how things change over time. So thank you, Mr. Green.
Right. And we've been married 65 years. Don't figure how old we were. We were young. That's it.
Well, thank you, Mr. Green. We are glad that you kept ACTS as one of the groups that you can still participate in. And thank you, Dr. Carrol. Naberta, please go ahead and come off mute and ask your question.
Hey, Dr. Carrol, thank you so much. I was late to the meeting, so I apologize if this question is redundant. It's twofold. One is I absolutely agree with you with regards to the promises and the things we say. I told my mom I wouldn't put her in a nursing home. Somebody said that the other day, and I told them absolutely don't say that. You don't know what you're going to do. And the journey has been long enough now that I tell people I do the best I can. But one of the things that I am concerned about is, being honest about healthcare and the disparities for African Americans. How do you go about finding some place that you feel comfortable is treating your loved ones, right? Not because of the color of their skin, but because of the care that they need. We've had a couple of incidents where I'm absolutely convinced that her care was not up to par until we got involved. And so I am concerned about that. So that's the first question. The second question I have is, unfortunately, we have now other family members who are getting diagnosed with mild cognitive impairment. And, I'm concerned about the cluster of dementia attacking the family. And so what do you do there, right? I'm getting calls from my cousins. We, are caregivers. There's already 4 girls who take care of the older 4. And now we've got a 5th and a 6th caregiver out of 12, or 6, 5th and 6th aunt and uncle that need to be cared for, right? So out of 12, right? It's like, so I'm curious with regards to, is there something that we as a family should be advocating for that next generation? And then lastly, how do you suggest we start having conversations about the what ifs? Because like you said, the time to get on the same page is before you need to get on the same page.
Mhm.
And I have 5 siblings. And I tell people, you know, it's like if you ask people where they want to go for brunch tomorrow, 5 siblings, 3 sister-in-laws, 7 nieces and nephews, you're going to get
It
21,
becomes too much. Right.
you get 21 different answers as to where the heck you're going to go for brunch. And you can just imagine when you start saying, you know, we just had to bury an uncle. And one of my brothers said, where's mom going to be buried? We're in Texas now. We're from California. We don't have anybody in California. Mom's from Georgia. And when I said, well, I think she wants to be buried in Georgia, you would have thought I was from Mars. I mean, my brother just looked at me and was like, where'd that come from?
Mhm.
I said, well, because I know she don't want to be buried in Texas.
Okay. So those are all good questions. So I think I'll answer the last one first. And it's a reiteration of what I was talking to Billy about. I think now I don't know where mom is on her journey.
She's in stage 4.
Okay. So when you say stage 4, are you saying mild?
No.
Okay. So you're probably okay. So it's a lot of different systems to use.
She's diagnosed with vascular dementia with behavioral problems.
Okay,
So
got it.
Your problem.
So the reason why it's important to have these conversations early is if we were able to have these conversations when mom or dad was able to participate, those questions we could have essentially answered. But if we didn't, then it comes down to who is responsible for making the decisions for mom from a medical standpoint, because then they would sort of guide that ship. Now, I'm not saying, Norberta, that if that's you, that you say, I don't care what my brothers and sisters say, this is what I'm going to say. So you still want to include their opinions, but in your best mind, you have to do what you would think mom would want. So often when we think of powers of attorney, we don't think about it like that. We think of it as she chose me and that's what I want. But it's really your mom or dad or whoever is supposed to select the person who would have not necessarily your best interest in heart, but they would make the decision that they think you would make. That's what the person is supposed to do, right? And so, but when we don't have those documents, it comes down to fighting siblings, fighting adult children, fighting ex-spouses, all kind of stuff. So I deal with all this in the clinic, by the way. So as much as possible, we want to outline it. And when it's not outlined, you know what I tell people? It will potentially be a stressful event trying to determine where mom will be buried. It will potentially be a stressful event trying to determine where we will have to place her if she needs to be placed. The best thing for you to do, Norberta, is to say, that's not going to happen to me in my generation. I'm about to write it down now for me, because you already going to have to deal with what's going on with your mom, but you have to start right now with yourself. If you have children or you have a spouse or whatever, writing that stuff down now, because I don't want to have to deal with that. The reason why that's important is it puts you in the driver's seat and it takes the stress off of your children if you have children. So we're not in the same situation. You know, we get caught up in generational dramas, curses, however you want to describe it, all the time. So we got to break that curse at some point. I think your first question, so that was the last question. Your first question was, oh, how do we select a place or something like that, right? Okay. So selecting a place can be very difficult because there are a lot of variables. One is location. I'm with you. So that's why it's a connection between California and Texas, by the way. So when it comes down to cost is a major factor. But just to let you know, sometimes the most expensive places aren't the best places either, though, because it's to them, sometimes it is just about the money. So you have to feel comfortable with the place. You have to perform pop-ups when you go there. Like, it's kind of difficult right now with COVID. A lot of people aren't really allowing pop-ups, and Norberta has a cat. So a lot of people aren't allowing pop-ups, but you have to feel comfortable with the place. The other thing that I tell people to realize, Norberta, is you also have to release the fact that no one will take care of mom as best as you would. You got to let that go.
That ain't my problem. That's my sister's problem.
Right. So the person has to let that go, because if you don't let that go, no place is going to work.
Right.
No place is going to work. So you have to start by letting that go, and then do pop-ups, and not only pop-ups, but make it known that you don't know when I'm going to pop up at this place. So anytime I come up here, mom better be doing okay. Now, you have to give them a little grace. Like, there may be some things can happen. There are multiple people that they're taking care of. So, you know, she may supposed to eat at 5, you get there at 5:10. If they don't have the plate in mom's room, you can't be out there making a scene, because these people are taking care of your mom. So you have to play that role. So I just tell people, try to find the best place. I also recommend trying to find somewhere that's close to you if possible, because the farther the person is away, it's not that they're out of sight, out of mind, but it's less likely for you to be able to stop by on the way home or things like that. You know what I'm saying? So having a plan for that. That's what I was.
Let me ask you a question. I had a friend, I did not know this, that those facilities have the right to kick their patients out. Her mother went to the hospital and they wouldn't allow her to be transferred back in.
Okay, so that probably requires me to know a little bit more information about the situation. That can occur if the person's care needs exceed that which can be provided, and the facility can provide data to suggest that we can't meet his or her needs anymore. Then they could potentially say they can't come back.
Yeah,
potentially. I mean, so, but that just shows you there's a lot of wiggle room for the providers there. Okay.
Yeah. Okay.
All right. I did want to answer Leslie Allen's question. Kimberly, she had, I think, put it on there for a while about, I think it was family.
I was going to go to that
interests.
next.
Okay, cool. Go ahead. Go ahead.
Okay,
Yeah, I'm looking at the
comment?
order that they're coming up.
Okay, got it.
I just want to make one comment real quick. When Aunt Lorraine was in the facility and she had to go to the hospital, we had to put her bed on hold in order to get her to come back.
In other words, pay some money.
Well, we had to pay no money to get
Yeah,
her
we
back.
did. They said it's $100 and some a day.
Oh, okay. I don't remember that part, but we did have to put the bed on hold to get her to come back. I didn't handle the money part. So
Thank you.
I don't remember that.
But just let me just say this. I was completely shocked by that. I mean, I don't know all of the particulars, but even still, who thinks that you have to pay when someone's not there? You know?
Oh, that's actually fairly common.
Okay.
Because these beds are commodities.
Yes.
And so if mom isn't there, then particularly if it's for an extended period of time, you may have to pay. Now, if it's like they went out overnight and they coming back the next day, you may not. I mean, you should still be covered by the monthly rent or whatever. Yeah. But often you do have to pay if you're like going into the next month and mom is at the hospital, stuff like that.
Okay.
All right,
go on to Tim's question, Kimberly.
Thanks, Brenda. Leslie asked, her mom and her mom's mother both have dementia. So she's asking, could this be a cause of concern for her and her siblings as part of family history like other diseases?
Yes. So actually, Leslie, there is some data to support that there are familial forms of Alzheimer's dementia. But that subset of forms that can be passed on from genes to genes and families to families is very small. There is some data, and that's why a lot of the research kind of is trying to target and identify those genes. When they identify the genes, it's a lot of correlation, meaning it doesn't necessarily mean that because you have this gene, you will get it. But what they say is these people have these genes and they had it. So it's a potential that you could potentially get it. I tell people that all the time when they say mom had it, dad had it, their parents had it. It could be that there's a genetic predisposition, but generally speaking, generally speaking, when it is in the genes, Leslie, the penetrance is really high. What does that mean? The penetrance of genes basically means that not only would mom and grandmother had it, but you'll hear people talk about grandmother's siblings all had it. And so when it's passed through the genes, it's gonna penetrate the family so intensely that it's like, when is my time going to be? Because everybody around me has it. Additionally, when penetrance becomes an issue, the penetrance is so high, and because it's in the genes, it starts impacting people at younger and younger ages because it's so intense. So then that's when you may have somebody who's 45 who start having problems. And earlier, I think you were on, Leslie, earlier when I was talking about when a patient comes with memory loss and they're 45, we have to approach that differently than a person who's 75, because we have to determine if this is a familial cluster. Like, what else going on in your family? Has anyone else had it this younger? So we have to look into it like that. Now, what I can say is sometimes it's not that it's passed on in the genes. It can be sometimes passed on in our behaviors. So what we're eating, how it can cause us to have diabetes, how it can cause us to have high blood pressure, how it can cause us to have cholesterol problems. So it's not necessarily it's passed on in our genes, but it's potentially, as I tell people sometimes, passed on in our plates. So that's why we think it's passed on in our genes. Does that make sense?
Yes,
Okay.
it makes sense. I have this. That's a good question. My grandmother as well as my mother had dementia, so I'll say thank you for both Leslie and I. I think she's on mute. Eric, you have a question? You want to come off mute?
Yes, hi. Can everyone hear me?
Yeah, we hear you. What's up?
Okay, I have two questions. The first one is about, you've been speaking about take care of yourself. That's the first one I'm gonna touch on, and then the second one is gonna be about the pills that offer for dementia. As far as taking care of self, the issue that I've been running into is my mother. She has a pension, and based off of her pension, things like that, it doesn't seem like there's any type of assistance to help with care. So if we need assistance, it's more like coming out of the pocket, and which, day by day is fine. But if there's ever a time where when we used to travel, we can't travel because how are we going to pay 24 hours for even minimum wage for 3, 4, 5 days? And I'm having trouble trying to find anything like that. I've given numbers 401, to call in, but then when I call the places, it goes all back to the finances, where it's like you make too much, but you don't make enough to take care of that part. So that's my first question or issue, if there's any insight on that one. The second one is, I had my mom taking Aricept, and we started off with 5 milligrams, and it didn't seem like it was doing anything. I understand you said there's no cure for it, but I was expecting, like, to slow down to see if everything keeps like the status quo. And they upped her to 10 milligrams. They said start with 5, and moved up to 10. And when she started taking 10 milligrams, it's like she started remembering things throughout the day, and I was like, fantastic. I was like, thank God. But then all of a sudden, it's like she started having, I don't know if she started saying that she smells certain things, and there was no sense or different smells, and she was complaining about, something smells bad, or, the thing about her saying she smelled is that her sense of smell was gone for over 3 years. And I know they say that that's linked to a part of a dementia and stuff like that, but her senses, this is before the COVID and everything as well too. So when she was saying that she was smelling certain things, I was like, nothing has changed other than her taking this medication. And so I ended up taking her off, and then that went away. And the question towards this, what built up to it, is that it seemed like it was working for a moment, but I'm concerned about her taking that, because she would just say things are like her sense of smell of smelling bad things, and there was no sense or no smells going on in the house at all. So I wanted to try something else to try and keep her at her stable state, but I'm concerned about trying a different medication for the memory. So that was the second question about the pill issue, and the other one about, you know, finding assistance for 24-hour care.
Okay, perfect. So the first question, I'll answer it in the order in which you gave it to me. So the first question is definitely something that we struggle with a lot, for that gap of care. So as you mentioned, the person is well above the poverty line, and often we use that term to determine when they can get assistance from the county or the state and things like that. But they are not to the point where they can, you know, pay for caregivers or pay for respite services and things of that nature. So that is a very difficult group to be in. I'm not sure if you have had the opportunity to try to apply. Mom has a pension, so she may not qualify for Medi-Cal or any support services like that. There are some new rules that just went into effect in January, so about 4 or 5 months ago, where Medi-Cal is starting to be a little bit more accepting of patients making more money each month or having more money in their savings and banks and things of that nature. But what we try to do within my clinic is one of my social workers tries to identify caregivers. He sort of kind of keeps list of caregivers or that have been worked for other families and tries to share that information with others. It can be rather difficult, Eric, to try to figure out how can we take care of ourselves if we can't pay for someone to take care of mom or dad. And so we just have to try to be as creative as possible. Rather it is shunting some of her money for her pension to try to take care of herself, or if she has property, using that, or pooling other resources to try to be creative, because this is something that could potentially also be a limiting factor if we ever get to the point where we need to talk about placement. Because often patients and families will say, Dr. Carrol, you're telling me that mom's needs are exceeding that which we can provide in home, but we can't place her because we can't afford it. So then we have to go through like a lot of hardship grants and different application processes. There is money out there to sort of help, particularly with respite. Now, I don't know, it won't necessarily be money for, you know, Eric, for you to use for a year. But if you were to say, you know what, I've been taking care of mom, me and my family just need a week off to go do this. There are respite care services that can be offered on very reduced fares. So that is there. So I would say if you can reach out to the Alzheimer's Association and try to find out more about respite care services, there's a defined amount of time that they will give you support for mom or dad so that you and your family can kind of go do something, because we realize the importance of you taking care of yourself. Does that make sense?
Right.
Okay. The second question was about Aricept, right? Yeah, right. About Aricept. So yes, Aricept is Aricept or donepezil. Aricept is the brand name, donepezil is the generic name. So that medication typically for the first month is only taken 5 milligrams, and then you increase it to 10 milligrams. The reason why we start at the lowest dose is because the side effects typically are dose dependent. So if you start at a lower dose, you'll be able to see if the person were to experience side effects. Now, I had not heard of someone having you said she could smell things, right?
That's what she was saying, but it really wasn't any smell that was going on. So it's more like
it's a hallucination. It's a hallucination. Yeah. So it's a hallucination. It's a hallucination where she's smelling things. And so that can occur with Aricept in general. It's very rare, and I don't think I've ever heard of the sense of smell hallucinations occurring. I've heard of gustatory, which you can taste things, but so that can happen. And generally when it happens, we do recommend stopping it. And I tell people all the time, because it isn't the cure, Eric, if the side effects are to the extent that it disrupts a patient's life or disrupts a family life, where it's like, this is too much, the best is to stop it, because it doesn't reverse it. It doesn't completely, stop it, So if the side effects are worse than what's going on, then the best thing is for us to cut it off or stop it.
Right. So
Now,
there is no alternative. Oh, go ahead. Yeah.
There are other medications in that same group of medications. There are cholinesterase inhibitors, which is what Aricept or donepezil is. We just often use Aricept because it's a once a day dosing medication. There are other medications in that same group, like a patch. You may have heard of the Exelon patch. And so it's a patch that can be used. There are some medications that are twice a day in that same group. The only thing is a lot of those side effects are specific to that group of medications. So you can ask mom's primary provider or whoever is prescribing the medication, is there another medication in that group that she can try outside of donepezil to see if she doesn't have that same side effects. Often people will use the patch if the person has a lot of problems with upset stomach, which is a common side effect. So they will use a patch which bypasses the stomach. And I have some patients that we have the patch for that they don't have the stomach effects because they're not taking it in their stomach. So you can ask the primary provider or whoever's doing it for that, if that's an option.
Okay.
Mm-hmm. But Eric, I don't want you to be wed to the medication so much that you cause that you disrupt, mom's day-to-day experience. If she's just having these hallucinations that are so debilitating for her, or if it gets to the point where she just doesn't want to do anything else because all she's doing is smelling everything all day, it's not worth it. If that makes sense.
Yeah.
Okay.
Thank you.
Mm-hmm.
So thank you, Dr. Carrol. Eric, do want to mention that we have another ACTS family member resource, Varnessa Aaron Seymour. She is a Medi-Cal Medicare contact, and you might be able to reach out to her to see if there's anything that your mom may be eligible for. So we definitely can provide her information, as well as Alzheimer's Los Angeles. You can call them to see if they have anything to offer regarding respite care. Sister Sharon, did you want to add anything to that?
Thank you, Kimberly. I believe USC, they have a caregiver program that they offer short-term respite. Varnessa's contact information is on the ACTS website under resources.
She can put it in the chat.
You can put it in the chat, please, Kim. And Alzheimer's Los Angeles, that's also on our website under resources. USC, I think we have that put on there. I'm not sure. But Eric, if you would like me to get that, I do know someone that did receive some assistance from USC for respite.
Yeah. Also, Sharon, don't forget about Ann Hospice that I'm using with my mom and all the resources that they're providing also through Medicare and no cost.
But that has to be when you're on hospice care, right? Yeah, that's why you're getting that.
Okay. Thank
But
you.
thank you. Mm-hmm.
Thank you. I will, while Ms. Foley, you're up next, while she's asking her question, Eric, I'll go ahead and find that information for Varnessa. I'll put it in the chat for you.
Oh, thanks, Kimberly. I know I'm taking my second turn, but I'll be quick. As I'm trying to prepare for our journey, I just want to know, how often should my husband see the gerontologist? And what should I expect to be happening there? And what part of his care should be primary medical care and his gerontologist? Because I'm not getting any direction, in terms of this.
Okay, so that's a great question. So each system is, well, fortunately or unfortunately, depending on how you see it, each system is a little different. So within my system, I solely focus on the memory care and evaluation and kind of navigating the journey. And I partner with the primary care provider to kind of help the patient as things changes. So they still take care of a lot of the medical conditions, and I take care of the memory, the dementia, the behaviors, decision-making, things of that nature. But as things progress, Ms. Foley, the person and their family starts to feel more comfortable with me. And so I sort of started to play a larger role, because as things progress, everything sort of just surrounds dementia in a way, because that kind of becomes like the main reason. I mean, yes, dad has blood pressure. Yes, dad has diabetes, but we don't even know if he's going to be willing to take his medication because he may be mad when he wakes up because of the dementia. So I sort of started to play that role. There's a lot of debate on how often patients should be seen. I generally tell people that I want to check in, or I will have some sort of contact with you about twice a year. Now, Ms. Foley, you may say twice a year. We got things going on in this house every day.
Yes.
But the reason why I say that is because anyone is one of me, but we don't expect a dramatic amount of decline from day to day. The reason why there's a lot of, we think it's a lot of changes going on every day is because with you being there every day, you feel like you're seeing these drastic changes, but it's all a part of the journey. And we don't expect you'll need to check in as far as, is this expected or not, until about twice a year. Now, at each visit, what should you expect? Should you always expect testing every visit? No. You should not expect testing every visit, right? And I don't do testing in every visit. What you should expect is a conversation about where dad is, your husband. I always say mom and dad, where dad is at that point in time, and then a discussion about the next corner that we could turn or the next part of the journey. So if you tell me, oh, I'm here with my husband and Dr. Carrol, he's doing okay, but he's starting to get a little confused about putting on his clothes. Like he'll come and it's kind of not buttoned correctly. Then I'm able to immediately place him on the staging criteria, which is what I was sort of talking to Norberta about. I'm easy to place him on the staging criteria. And then I'm able to say the next step could be that he needs, if you were to tell me that dad is unable to pick out his clothes, like he doesn't know what needs to be done. Like he's trying to put on clothes like he's going to sleep, but he's saying he's leaving the house to go to the store. So then I'm able to quickly place him on the staging criteria, and then from there able to determine the next step could be when you pick out his clothes for him, because you're having to do that now, he may get a little confused about buttoning it, because we expect that to be the next stage in his progression. So what you should expect on the visit is not necessarily a test, but a discussion about where he is, a discussion about if he or she can still make decisions for himself, a discussion about, caregiver stress, a discussion about, what else could I say? Incontinence. That's always a big thing, because that's a caregiver stressor. If the person can't take care of themselves, it's like you have a baby you're taking care of. So a discussion about where the person is in their progression. So that's what you should expect in those meetings.
Thank you very much.
No problem, Mom.
Next up, thank you. Next up, we'll have Joy.
Okay. Thank you, Dr. Carrol. The
No
information.
problem. Joy, you've been holding me down. I've been seeing your hand for a while. So we're here now. We're here.
I'm so thankful that you're on today.
No problem.
Our family went through an ordeal with my father, who was diagnosed, and he was high functioning and had Alzheimer's for 16 years. And probably 98% of the time he was pretty high functioning, and then a rapid decline at the end. Well, my sister has been diagnosed with early onset about 5 years ago. My question to you is, my father was very high functioning, and I know that the dynamics of this disease are different for everyone, and it's so varied, But my question is, my observation is that my father did not suffer with depression. However, my sister did previously. And what I'm seeing is a faster progression. She is not on a medication for the Alzheimer's. And I don't believe that she's taking anything for the depression. Is there a correlation between those who have suffered with depression, getting Alzheimer's later and it progressing faster,
And the fact that we know that, you know, those medications for Alzheimer's are not a cure, should we more so turn our focus toward maybe, you know, treating the depression? Because maybe some of her motivation to not want to get up and do things, could it possibly be that she's depressed and that's why she, you know, really doesn't have the motivation to get up and do anything?
So that's a great question, Joy. So just to clarify, when you say that your sister had depression, are you relating that to her seeing dad's decline? She was depressed, or she just been depressed like for her life, in her whole life? Okay, got it. Okay, all right. So yes, believe it or not, the connection between mood, I'm going to say depression being mood, and memory is so intense that there used to be a term that we would use called pseudo dementia or fake dementia years and years ago. We don't use that as much anymore, but pseudo dementia basically means when a person's depression has gotten to the point that it clouds their memory by directly impacting their ability to focus, concentrate, and pay attention. So sometimes when a person is depressed, they can walk in the room and you will think that they have dementia. Okay. So what we recommend is treating the depression first and then seeing them back in about 3 to 6 months to see if those symptoms improve. Now, I'm not saying that your sister doesn't have dementia, she really has depression, but the opposite can occur as well. When a person truly has dementia and they have a difficult time coping with it or accepting it, particularly this is very common in patients that have early onset.
Okay.
So they just can't connect with the fact that I'm 55 and you telling me that I can't think. And then they're also thinking about what their parents' experience was, what the next door neighbor's experience was with dementia, and it truly does cause them to decline. In situations like that, I tell people all the time, I rarely see early onset because I only see 65 and above, but when I'm pulled into cases, for rare cases that the person may be 50 and neurology wants me to comment, I will say this. I recommend, rather than starting on a cholinesterase inhibitor, the Aricept and donepezil, we should target the mood because that's something that we know we can actually target. We know that that can be improved because if you are supposed to be here, Joy, and even with dementia, you're supposed to be here, but because of the depression, you're down here. If we treat that depression and it gets you back here, then we're doing you a service. But if we focus solely on, oh, I need to give her the medication for dementia because that's what it's for, we're doing you a disservice. Okay. So also it's important for your sister to acknowledge that she's depressed.
Okay.
And you know, we have a problem sometimes accepting what depression is.
Yeah, she
that we're depressed.
She doesn't suffer, but she's not in denial at all.
Good. Okay, good. So getting her to accept that and getting her to accept that by treating the depression, we can indirectly or directly treat the memory.
Okay.
So sometimes people can't make that connection because they're like, this doesn't have anything to do with my memory. You're like, it could, because your memory's so clouded by the depression and feeling down and woe is me and you know, this is what's going to happen to me next. And Joy's going to have to take care of me hand and foot eventually. If we can treat that, then we may actually help you overall.
Okay, wonderful. Thank you so much.
Anytime.
Thank you. Lisa?
Good morning. No, good afternoon. Hi, Dr. Carrol.
Hey there, how are you?
I'm good. You're actually my mom's memory care provider.
Oh, nice.
Yeah, so thank you very much. A couple of things. I'm always concerned with traveling with my mom because in addition to the memory issue, she has other medical issues. And on our last travel, we were flying back from the South and she literally had a serious nightmare on the flight and, you know, that concerned me. And then the other thing is I'm having a few issues with her independence. I tell her, Mom, you can't lock the bathroom door, you know, when you go in the bathroom, in the case that you fall, that doesn't matter because regardless of what she does in the bathroom, brushing her teeth, she locks the door. So I'm thinking at this point, I may just have to take the locks off the door.
Correct. Yeah, start there.
Okay, so that's one thing. And then just anywhere we go, I tell her, Mom, you have to carry a cane. She feels that she never has to carry a cane because she can walk for however long she needs to walk without her cane, without any support. So besides, in the case of the bathroom, that's an easy one, which means just take the lock off the door. What else can I do to try to help force her to understand that she needs help? She needs to, rely on us, and from there. You're on mute.
Sorry about that. So it's always going to be a somewhat difficult conversation for getting people to accept that they're changing. It's always difficult for them to accept that Lisa, my daughter, is now telling me what to do. So you got to think about the psychology of that. When I talk to people about assistant devices, whether they be canes, walkers, glasses, hearing aids, any sense like that, I always try to reverse the conversation by saying, we want you to use this cane, we want you to use this walker so you don't have to hold on to Lisa. Because I know you don't want Lisa to have to guide you around the house. So we want you to be as independent as possible. So you just have to use this cane. And I've had people decorate the canes, put, all the kind of stuff. So, and you may laugh, Lisa, but stuff like that psychologically helps them understand this is why I need it. They'll give the cane a name, all this kind of stuff, And so trying to get them to buy into how your independence can be furthered by accepting this supportive assistant device. And not that I'm dependent on it and I can't do anything without it, right? Now, the first thing about traveling is a very difficult, it can be a difficult conversation because we don't know. And that's one of the what ifs that I often talk to families about. I very rarely tell people they should not travel with their loved one, unless I know it's fairly advanced and I don't know what to expect. But I always tell them that because we don't know what to expect. The biggest thing that can happen when it's a very long trip is if the person does go to sleep and wake up, because our level of confusion in the setting of dementia is worse falling asleep because you're in that twilight zone and waking up. So that's what I can't, and I do this every day, I can't predict how Mom will be when she wakes up. I really can't. There are medications we can use to try to keep Mom calm that can make her sleep and potentially make her sleep a little longer. And it could prevent the fluctuation of the anxiety that could occur. Like she waking up like, well, where am I, But I'm still not the one to say, give her this medication regardless, because we don't really know if that can happen. So what I tell people to do is when the person does go to sleep, you can't go to sleep, Lisa. Because you got to be ready, because you don't know what Mom gonna do when she first wakes up. So the best thing for her to do is to, hey, Mom, we're on the plane on the way back home. We'll be there, just trying to talk to them very, softly and soothing. If you feel comfortable telling the people around you that, I don't know how she's gonna wake up. So having that conversation early so that it's not like this was going on. So just trying to be as soothing as possible, because I don't necessarily say give Mom medications to make her sleep the whole time, because that's not really the goal, but it's just always a thing. And that can occur not only on the plane. I had a patient here recently, family went to Vegas for a reunion or something, and they woke up in the hotel, same exact situation. Now, and of course, when you travel, you do have to sleep at some point, so you can't just stay up the whole time, Lisa, but it's that same concept of we don't know what we're going to get. And I still tell families they should travel with the person as much as possible, but just being aware that there may be some rough days there where we might not be able to go down to the casino floor because we don't know what Mom is doing or how she's going to take it. But I don't want you to feel like, you know what, Dr. Carrol, I can't even travel. Like I'm about to grow myself crazy. So you got to try to find that balance.
Thank you, Dr. Carrol. Sister, did you want to chime in there? Sharon? You're on mute. You're on mute.
Unmute, thank you. Lisa, like when Mother Peggy, she did not want to have that handicap parking placard. And so Vivian told her, this is because this is preferred parking for you, Mother. You gotta be a therapist, a psychologist, you got to be all kind of different roles.
As therapeutic lies work. Therapeutic.
Are they therapeutic for us or for them?
Both.
Everybody.
Mainly for our peace of mind.
Woo, child.
And Roberta can tell you about that traveling.
I'm surprised you didn't jump in, Roberta.
You're on mute,
You're on
Roberta.
mute.
Get off of mute, baby.
I said, I took mom to Atlanta, Lisa, and she screamed and screamed until we got in the car to get to the airport. She said, we're going to the airplane. And then she turned into Academy Award actress. She didn't scream again till we got to my auntie's house. But coming home, when I tell you, I wanted to have a drink because mama showed out. But I agree with Dr. Carrol. You just don't know. And the amazing thing was the people who had compassion, they understood. And I just said, what can you say other than, you know what? It's not a good moment. And hopefully it gets better. And it got better. It's a 2-hour flight to Atlanta. She screamed for the first hour and then she switched and she was good for the last hour. But those people on that plane, I was like, ooh.
But Berta has shared with me how the people who worked, for the airline, they were like, that's okay. Your mom's going to be okay. They were very comforting. And then as people passed them getting off the plane, they were like, have a nice day, right? So nobody gave her an evil eye or anything. So people understand. I mean, unfortunately, it seems like people are having more knowledge around dementia because it just seems like more people, unfortunately, are getting it. So, yeah.
And then the other thing, thanks, Kimberly, for bringing that up. The other thing is I am so grateful that we took Mother because her brother passed away a couple of weeks ago, and it was the last time she got to see him.
And that brings up a very great question. I often get asked a lot, and I will need to step away right at 1 o'clock. I'm actually on call today, so that's why you see me looking down at my phone every now and then. But so that brings up a great question about when families often say, well, Dr. Carrol, can I take mom to a funeral, or can we go back to Georgia because her brother died? I try to leave that decision up to the family because I never want them to think I prevented mom or dad from going to spend that time. I just tell them, you just need to be aware of the risk. It could potentially be an emotional experience. And if depending on where the person is in their journey, they may not be able to manage all those emotions. So if people crying, falling over the casket, that may be too much for them. Okay. So you may be able to have them go to the wake, but not the funeral. But I don't want to limit you or your mom or dad from seeing that experience because those family meetings are important, but we have to accept what could happen, but still try to be able to participate with the family.
Mm-hmm. Well, Dr. Carrol, I'm going to thank you from ACTS for coming today. God answered prayer. I prayed that we would be able to get all the questions answered in the time we have. There's no more hands. There's no more questions in the chat. We really appreciate your time today and the knowledge that you shared. Thank you so much. Everybody, can we give them a virtual clap?
Yes.
Yay, yay, yay.
Yeah.